We're here today with the Utah Valley Hospital Structural Heart Team to discuss the topic of aortic stenosis and what to do next if you have been diagnosed with the disease. With us is Medical Director Nirmal Sankara, Cardiovascular Operations Director Mitch Southwick, and Cardiovascular Supervisor Kristen Keaton. Dr. Sankara, could you start off by telling us what aortic stenosis is?
Aortic stenosis is a problem of the aortic valve within the heart. Aortic valve is a one-way valve that sits between the bottom left pumping chamber of the heart, which is called the left ventricle, and the main pipe, which takes blood all over the body, called the aorta. This valve is supposed to open with each heartbeat and close, preventing any backflow into the pump. This valve tends to degenerate over time. When we are born, the leaflets of the valve are pretty thin. They're about maybe thinner than this piece of paper. But as we get older, they tend to become thick and brittle. And when they become thick and brittle, they don't open as well as they should. And sometimes they don't close as well as they should. So when the valve doesn't open, the pump has to work extra hard to push blood across that valve. And that means that the body is not getting enough blood, or the heart is working too hard to even pump a little bit of blood to the body. This manifests in a few ways. Sometimes it is chest tightness or shortness of breath when people are walking around because they're not getting enough blood when they start to walk or exert themselves. If there is not enough blood going to the brain, it causes people to have dizziness and people to pass out, especially when they're exercising or exerting themselves. The heart tends to give in over time, meaning that the pumping chamber itself becomes weak. And when it does become weak, it tends to not be efficient in terms of pumping blood. So all these other problems become compounded. And when it becomes weak, it also tends to back up into the lungs. So people develop shortness of breath when they're laying down. They tend to have difficulty breathing when they go to sleep. Sitting helps breathing. People feel better when they're sleeping in a recliner or sitting up. And then people start noticing swelling in their legs, which again, once aortic stenosis progresses to this point, that there are symptoms, it tends to lead to ultimately death within a short period of time, which is about 6 months to 2 years once these symptoms develop.
Okay, so Dr. Sankara, if you are a referring physician and you're seeing a patient with aortic stenosis, what are the current treatment options available for them?
Yeah, aortic stenosis traditionally was treated with valve replacement through open heart surgery. More recently, in the past 15-20 years, we've had extensive development in that field where we are now able to implant valves without doing open heart surgery. This is called minimally invasive valve replacement. We do that through typically by going in through a patient's leg and implanting a new valve. Sometimes if for whatever reason we're not able to use the leg, we can use other access areas like the neck or the shoulder area to access the aortic valve and replace an aortic valve. So this technology is currently available as well.
You know, if I could just add to that too, Dr. Shankar, it's interesting. Open heart, it's often referred to as SAVR, but it's basically a surgical aortic valve replacement. And nationally, you see a trend where SAVR, or surgical aortic valve replacement, has actually been trending down historically. One of the nice things about our geography here in Utah is we have a growing population, so we don't see that same significant trend. But what we do see, which is a national trend, is TAVR, or transcatheter aortic valve replacement, is drastically, or at least increasingly growing, which again aligns with the national trends, and it really is a testament to the success, particularly the 5 to 10 year data that we're seeing. 15 years ago, all you could do was get pretty extensive in surgery, right? I mean, an open heart surgery is nothing small, it's a big deal. And we won't expound on that necessarily right here, but basically you have to actually go in through the chest cavity and do some incisions, and now with you just go in through the femoral artery and you come up and you just release that little balloon, and all of a sudden you have a new valve. It's pretty fascinating, the technology we've achieved at this point. So one of the things too that, and Dr. Sankara, you can speak to this, it's fascinating. Every patient does not have the same heart size, capability. The valve placement has to be different, right? Maybe talk a little about how you go about strategically planning that, the imaging technologies and so forth that we have to utilize.
Yeah, you're right. Not every valve is the same size. Not every valve is located the same. You have to take into account the surrounding structures when you're planning for this. So there is a lot of thought that goes into picking a valve, the type of valve and the size of valve for a particular patient, and the access approach for that patient. We do extensive imaging before the procedure. We do CT scans from the neck all the way down to the leg to understand the internal anatomy, as well as understand the type of valve, the size of the valve, the relation of the valve with the surrounding structures. And once we have that assessment, then we sit together as a team and we discuss what is the right option for this patient. A lot of thought goes into picking this type of valve for the patient, not just current situation and current anatomy, but future considerations as well. You've touched this before. This valve, this technology is now approved for lower risk patients. What does that mean? That means traditionally people who are younger, who do not have high surgical risk, who would be great candidates for surgical aortic valve replacement, can potentially opt for this treatment as well. This is available for them as well. Now, when offering this to them, again, this is where our team does a great job, is the thought that goes into offering a particular procedure or a valve for these patients. You have to not only consider the immediate procedural risk and the recovery times, but you also have to consider what could happen in the future with these valves. Now we have good data that these valves do well up to 10 years. Like you said, we just don't have the 15, 20-year data yet, which we'll potentially have in the future. So what should we do if this valve were to not function as expected at 10 years? So that goes into our thought process as well when we are planning a particular valve for these patients. Again, that's where I think our team shines, is having that discussion as a team, deciding on what particular valve suits best for that patient situation. Now, this is obviously done with the patient's input as well. Patient preference does matter in this. If a patient were and we present these options to the patient, and ultimately we have a discussion with the patient as to what the best next step for them would be.
Chris, and as we're talking about TAVR and so forth, it'd be interesting to see from your perspective on the clinic side, the referral process, what questions patient asks our team. Maybe talk a little bit about from the staff perspective.
For sure. So when we get a referral for aortic stenosis or for a transcatheter aortic valve replacement, maybe from another provider or consult for that, we have a multidisciplinary approach to that, just because patients do have a lot of questions. We need to make sure that Dr. Sankara is able to answer those questions, but we also have a clinic MA that is dedicated to just kind of managing the flow of those patients from the ground up when we receive that referral, alongside our structural heart nursing coordinator, who is Liz Bear, and she is amazing. She's very involved from start to finish. If patients have questions, they are always able to ask her. And patients have a lot of questions, I think, about timelines for when they can do this, what types of valves, why they're a great candidate for this, and how they should proceed with their care in the future, what to expect in the future, just where many may not know much about it prior to being introduced to this. And so what would you add to that?
The biggest surprise to me about what patients are concerned about, especially when you're dealing with older patients, is this tendency to, one, dismiss their symptoms, thinking that this is probably related to old age, and also this concern about heart valve replacement or heart valve surgery. They're worried about how much of a burden they'll be on their support system. I think that's a big question in patients' mind that I've realized. Obviously, they're concerned about the type of valve and the surgery and the risks and benefits and all of that, but their primary questions are related to the recovery time, the time involvement for, not mainly for themselves, but for their support structure. And that's a very valid question. And it's significantly different between open heart surgery and transcatheter aortic valve replacement. We tell our patients that this is a process which involves multiple steps, and we try to minimize the number of steps as much as we can for patients, make it convenient. And some of the steps are obviously, one, we need imaging studies. We also do angiograms to check for any heart artery blockages before we proceed with valve replacement. So we try to arrange the angiogram and the imaging studies on the same day, so it minimizes trips for patients. They'll meet the rest of the team in another setting, which could be the same setting when they come in for the angiogram, again, to minimize and make it convenient for patients. We have patients coming in all the way from Monticello, San Juan, and we try to minimize the number of trips they need to make to the hospital before they can actually be scheduled for valve replacement. And once they're good candidates for transcatheter valve replacement, the process is usually they come in for the valve replacement, they get the replacement done. More than 90% of our patients go home the next day. They're able to get up out of bed and walk around typically the same day, and the next day they work with cardiac rehab and they go home with family support. I think that's one thing that many people are concerned with in terms of how many days they need to be in the hospital, how about the family members they're already caring for at home, how to arrange support for them, things like that. So that's definitely one concern. The other concern is obviously the risks. This is open heart surgery. There are risks associated with it. The risks are comparable based on multiple studies we have done. Some show TAVR is a little bit better, some show surgery is a little bit better, but I think overall the data suggests that both are similar in terms of risks, which is about 2 to 5% risk of something major happening, like a major heart attack, stroke, or death on the table. There is about a 5 to 15% wide range, but up to 15% risk of needing a pacemaker after the procedure. So we typically monitor patients in the hospital while they're in the hospital to see if they'll need a pacemaker. If not, we typically send them home with a monitor, so we continue to monitor them for up to 30 days after the procedure. But typically, the need for a pacemaker is identified within the first 24 hours, so while they're in the hospital. If they do need a pacemaker, it is a much simpler surgery compared to valve replacement, and we get that done before they leave the hospital if they show that they need a pacemaker before they leave the hospital. I think those are some of the things that people tend to be concerned about.
And one of the things I just want to hit on from a benefit perspective that's similar to surgical is it's very much a multidisciplinary team, right? And come back to the surgeons, it's fascinating. Some of them will encourage their patients to have a TAVR versus surgical, right? Depending upon those patients and what they need and what's best for them. Because in a surgical setting, right, you're in the hospital post-surgery minimum to 5 to 7 days. And, TAVR, we're not doing it, but there are, it's almost same day practically, right? And I don't know that that's necessarily the best way. We could talk through the research in the future. But for sure, there's great opportunity where it's a day or two, right? I think our average length of stay here is about one. It's like literally less than one full day of 24 hours. It's amazing how we've come and, brought that service here. So I think that's a big benefit to our team is they're not sitting here, our patients more so. They're not sitting here for 5 to 7 days in the hospital. That care from family, they're sitting here, they're taking work off. From a TAVR perspective, they may take a day off, but or two, but they're home after that, which is a very fascinating benefit to our community and our patients.
Kristen, can you talk a little bit about if a referring provider has a patient with aortic stenosis, what's the process in getting in touch with us, or how do they send the patient to us?
They can always contact our office by phone. It's at 801-357-4600. They can also fax some patient information over, any imaging that they've had over. We can always request any physical imaging copies and have that pushed through. But sending that referral by fax is probably the easiest way, and we can make sure that we include this fax information with this podcast.
Excellent. One final thing I wanted to highlight was when to send these patients to see a structural cardiologist. I would say the best time to send them is as early as possible. What that means is once you hear a murmur or once you start noticing patients having symptoms suspicious to be related to the heart, send them over. We'll take care of the investigations and we'll figure out if they need an intervention, or if they need just follow-up, they'll come back to you, and we will continue to monitor them periodically in coordination with you and your team. Thank you.